Hello and welcome to session 5 of our 6-part series, Suicide Intervention and Response for Youth Experiencing Serious Emotional Disturbance. My name is David Terry, and I am a project coordinator for the Mountain Plains Mental Health Technology Transfer Center. As we have noted, the work of the Mountain Plains MATCH-ADTC and Mountain Plains PTTC is supported by SAMHSA and DHHS. We would like to note that today's presentation is provided free of charge and is available in the public domain. Also, the information presented today are the views and opinions of Dr. John Paul Legursky and do not reflect the official position of DHHS or SAMHSA. Please let us know if you have any questions about the information in this disclaimer. Again, welcome. It is my pleasure to introduce our presenter today. John Paul, or J.P. Legursky, is an associate professor at the University of North Dakota, Department of Psychology, where he teaches graduate and undergraduate courses in child psychology, theories of psychology, therapeutic interventions, and development across the lifespan. His primary research interests focus on the interplay between emotional, developmental, memory, and psychopathology. He is a practicing licensed child psychologist and is the clinical director at the Northern Plains Community Clinic, an interdisciplinary clinic that serves individuals and families living in rural North Dakota. A quick note, unfortunately, part of today's presentation was lost irreparably due to a technical issue. We do still have the latter half of JP's presentation available for viewing. I would encourage you all to view today's presentation as JP provides a great overview of assessment and response for children struggling with SED or serious emotional disturbance and suicide. However, the first half of JP's presentation is missing. The slides for the presentation, however, include all of the information, so I would encourage you to access that if you would like to get more information on this topic. And we hope that you find this helpful and apologize for the technical issue. Thank you so much.
So thus far, we have discussed risk and protective factors for suicide. And I've provided an overview of cognitive behavioral therapy, one of the most common and well-established treatments for depression, depression being one of the biggest risk factors for suicide. Another common intervention for depression is interpersonal therapy, frequently called IPT. IPT is an intervention that has been used both with adults and youth, particularly adolescents. There is a current treatment manual called Interpersonal Therapy with Adolescents developed by Munson in 2004. It is a time-limited intervention that focuses on the interplay between depressive symptoms and a client's current interpersonal difficulties. As you might recall, interpersonal disruptions, i.e. social difficulties, are oftentimes a major risk factor for depression and suicide. IPT for adolescents treatment sessions are divided into three phases or stages. The first stage focuses on the evaluation of depressive symptoms, psychoeducation, as an assessment of interpersonal relationship difficulties that will be the target of the intervention. In this phase, you are really trying to identify what type of interpersonal difficulties they are having so you can target that for the subsequent stages or sessions in your treatment. During the second stage, the therapist helps the adolescent learn specific techniques that can help them negotiate the interpersonal difficulties they have identified in stage 1. And then in the third stage, in the final stage of IPT, it focuses on the preparation and initiation of terminating the therapeutic process. In IPT, you develop a relationship with your therapist. Relationships are thought to be important, so there's a heavy emphasis on closing that relationship in the final stages. with IPT, one or more four types of interpersonal difficulties are assessed, identified, and targeted for treatment. This can include grief, a loss of a loved one, whether through physical loss, due to death, or perhaps being displaced through divorce with that relationship. Another area is interpersonal disruption, interpersonal disputes with friends, teachers, parents, or siblings. Another area is role transitions. So, for example, changing schools, illnesses of a parent or sibling. Finally, interpersonal skills deficits. So treatment depends on which types of interpersonal difficulties a client might be experiencing. For example, if a person is displaying a lack of interpersonal skills training is the focus. In contrast, if grief is one of the major presenting interpersonal difficulties, treatment is geared towards helping facilitate that grieving process and conveying acceptance to the client. A number of studies have shown that IPT is well established and an effective form of intervention. Thus, if interpersonal difficulties are present with depressive symptoms, IPT might be the treatment of choice. So we see here that there is not a one-size-fits-all approach to treating depression. If we see that a client has more interpersonal difficulties, we might select IPT. If interpersonal difficulties aren't on the forefront, we might turn to traditional cognitive therapy. Finally, I'd like to talk about medications. Medications are often used to supplement or as an alternative to the psychotherapy approaches we've discussed thus far. There are two major types, tricyclics and selective serotonin reuptake inhibitors, known as SSRIs. Recent research has shown that the tricyclics provide little to no benefit over a placebo when treating depression with youth. So really we're seeing much more common use of SSRIs to treat depression. SSRIs have shown to be more effective than a placebo. So despite substantial evidence that SSRIs were effective at reducing depressive symptoms, suicidal ideation, and suicidal behavior, in the early 2000s, anecdotal evidence began to emerge from the media suggesting that SSRIs might place youth at increased risk for suicide. This ultimately resulted in the U.S. Food and Drug Administration placing a black box warning on SSRIs for children and adolescents. This began in 2004. So what we see is this introduction of this black box warning combined with the stigma that is associated with taking medication. This combined influence resulted in a drop in the use of SSRIs, one of the most proven effective medication interventions for treating depression in youth. This being despite the fact that research supporting actual increase in suicidal ideations due to SSRIs was very limited at the time. So in the following years, since the black box warning, this inclusion of this warning resulted in a decrease in antidepressant usage among youth. As we saw this decrease in the early 2000s, many health providers, doctors, and researchers raised concern that the more significant danger was that the black box warning had resulted in a reduction in the use of SSRIs, a well-established intervention for treating depression. A more recent analysis of medication usage from 2005 to 2012 in the US and 4 European countries has shown, however, that any reduction in SSRIs usage among youth caused by the black box warning was short-lived. And we've seen a continued, in the last 10 to 15 years, a continued increase in the uses of this medication approach for treating depression. There's a couple of reasons why I like to discuss this, just because I think it's important to be informed. I have interacted with a lot of families who are very hesitant to utilize medication, and some of them might recall this controversy 15 or so years ago. So I think it's important to talk about and help the public and the families you work with be informed so they can make the best informed decision. Of any risk associated, the marginal anecdotal evidence that did show any risk of suicide did indicate that if there was a risk, it would present itself immediately after or a few weeks after taking the medication. So that's a time when doctors, teachers, and especially parents should carefully monitor a child if they're put on SSRIs. So thus far, we have discussed 3 of the most common treatments for depression among youth: cognitive behavioral therapy, IPT, and the use of medication. Now, what I'd like to do is introduce a case study. This is a case study on Billy. Billy is a fictional character. This example is an amalgam of clients I've worked with over the years. But Billy serves as a prototypical case, a case that would be very familiar to anyone that works closely with children. So a therapist was assigned to work with Billy, a 10-year-old European American male. During the summer, Billy received a detailed psychological evaluation where he was diagnosed with ADHD combined type, specific learning disorder with impairment in reading, and oppositional defiant disorder. During his intake, Billy's mother indicated that he has a long history of academic, behavioral, and emotional regulation difficulties at home and at school. His mother also indicated that Billy is very impulsive and reported that Billy has been suspended on 3 occasions in elementary school for physical altercations with other students. When inquired about these fights, Billy stated that he hit the other students who were teasing him. So this is a presentation on depression, but we are talking about ADHD, LD, and conduct disorders. Why are we doing that? Well, before I get to that, let's talk about some of the strengths that Billy has. When working with clients, I like to develop what has been coined a diversity resiliency formation. This perspective emphasizes assessing and focusing on strengths that the child has. So taking a strength-based approach, we can look, Billy's therapist looked at through interactions with Billy, his teachers and parents to identify individual characteristics, resources, and other factors that might aid in Billy's treatment. This diversity resiliency formation, this perspective necessitates assessing relevant intrapersonal, interpersonal, community, spiritual, and cultural factors. So when we're speaking with Billy, his mother, and his teachers, the therapist identified that in terms of intrapersonal strengths, he's of average intelligence, he enjoys sports, he lacks complete indifference, which doesn't sound like a strength, but it actually is. He demonstrates jealousy with his siblings. He responds well to one-on-one tutoring and attention. He likes music, especially percussion. He wants to be a drummer. Get some of that physicality out. In terms of interpersonal strengths, his parents and teachers describing him at times being very loving. He has an intact family. He has a positive teacher and school setting, and his parents can afford treatment. In terms of community setting, he lives in an middle upper class community where there are many extracurricular activities available, and there are no negative role models. There are few negative role models in his environment. In terms of spiritual, his family attends a Presbyterian church, and in terms of cultural, his family identifies as white and they're of Scotch-Irish origins. So now that the therapist has been able to identify some of these strengths, these can serve as points of intervention. The therapist can utilize these to help facilitate and implement treatment. The diversity resiliency formation really emphasized the environment and the context of the child. So one of the approaches that you often see is the development of what's known as an eco map. An eco map is simply a way of the therapist to work with the child to map out their social support network. To have the child identify which areas of his network might serve as strengths and which areas of his network might be problematic or strained. So in this activity, what you'd have the child do is take a piece of paper, have the child write their name in a circle in the middle. And then you have the child identify important others in their relationship. The closer the person is to the child, they should write the name of that important other closer to them. So you can see from this picture, we have a bunch of people in Billy's life. You have his mother is Elizabeth, his father John, his neighbors, his spunky dog. And as you can see, some of these people are closer on proximity in this map than others. That shows a more closer and important relationship. Another thing that you'll notice here is that you have some solid lines and some lines with lines crossed out or through them. The solid lines, like the one to his mother, signify a strong relationship, someone he perceives as being supportive and positive. The lines with hash marks in them, such as his father, represent relationships that are strained. So you can see that here, through utilizing this map, you can see that Billy is experiencing a lot of support from his mother. He views that his dog, Spunky, is someone that's important to him, although he has expressed some strain in this relationship with his peers, with his brother, some of his neighbors, and his father. This is thought, these echo maps are kind of a dynamic assessment procedure in that you would return to this every session and make changes as needed. Some people might be added to the lists, the relationships might change, people might move closer or further away in this map. But this can provide you with a lot of information. If there are a lot of interpersonal difficulties, you might want to focus on developing interpersonal skills. This is really, if we say pronounced depression, we might focus on that IPT that we discussed earlier. Now let's continue. Let's talk about why we're discussing Billy in the context of depression. Well, let's go back to what's happening with this therapist. Billy's family decides to come to therapy to address his behavioral problems. And the therapist works with his mother to develop a treatment plan to address Billy's disruptive and aggressive behaviors at home and at school. The treatment focuses on behavioral management training for his parents. Following a treatment manual for conduct problems, the therapist meets individually with Billy, while another therapist meets with his mother to provide concurrent parent training. Over the next few sessions, Billy displays some small gains in reducing his disruptive behaviors, and his academic performance begins to improve. He appears to enjoy meeting with a therapist each week, but during the course of therapy, he often expresses frustration with his perceived lack of progress. Billy often makes self-defeating comments about his academic ability, saying things like, "I'll never get it," or "I am hopeless." His mother reports that he has shown an increase in his tardiness at school. Billy says he's been oversleeping and he doesn't want to get out of bed, which has caused him to be late. He also expressed irritation with his friends, saying that he no longer spends time with them. At home, Billy spends his afternoons and evenings sleeping or playing video games in his room by himself. He has even stopped going on hunting and fishing trips with his grandfather. When the therapist inquires about these recent changes, Billy becomes tearful. He shares that he is being teased by his classmates and says he doesn't want to go to school anymore. He adds that his academic workload is just too much, and then he wishes it was all over. The therapist has Billy complete a brief self-report measure of depressive symptoms, and his scores are well within the clinically significant range, meaning that his scores on depression are very high and warrant treatment. As you can see, consider Billy's current circumstances, how would you respond? How would you suggest that the therapist responds in this context? What factors may place Billy at risk for depression? From this vignette, we see that he's expressing a lot of interpersonal difficulties with peers at school. He has also disclosed feelings of helplessness. These should definitely be red flags for depression and for suicide. He's also, his score on the depression measure that we used were also very highly elevated. So with this vignette, you can see that the therapist would be presented with a problem. How might they proceed in treating and addressing these depressive symptoms? Should the therapist discontinue the parent training to address Billy's conduct-related problems? This case example is likely very familiar to mental health professionals treating children and adolescents in community settings, where comorbidity, i.e. multiple diagnoses, is frequently the norm rather than the exception. When encountering multiple diagnoses, each with different indicated treatment approaches, providers are often questioned about target priority, which symptoms to address when, and concerns about treatment fidelity. Will a treatment be effective if I transition from one treatment to another? When surveying mental health providers regarding barriers to providing evidence-based practice, one of the most often cited concerns is that cookie-cutter, evidence-based, or manualized treatments are often too inflexible to meet the array of mental health needs presented by real-world clients. So what to do? The American Psychological Association created a task force, and they developed what was known as evidence-based practice to address some of these concerns in assessment and treatment. They postulated that 3 important ingredients are needed to provide best practice with clients like Billy. I'm going to base my suggestions on this approach. So effective treatment for Billy must rely on 3 important ingredients. The first being clinical expertise. The treatment provider needs to be well trained. This is important both for assessing, clearly assessing, delineating, identifying the disorder, and also to have backgrounds in a variety of treatment approaches. The second ingredient is that the treatment provider must have access and knowledge of interventions that are based on the best available research. There needs to be known to the therapist what treatments have shown to be effective, so that they can prioritize what's known to be effective over those treatment interventions that are known to be ineffective, distinguishing the psychological science from the pseudoscience. Third, the therapist must take into consideration the client's values, characteristics, preferences, and circumstances. What are Billy's circumstances here? His circumstances might warrant the need for flexibility in adopting a treatment approach. So we've discussed a lot of evidence-based treatment interventions here. There are evidence-based treatment interventions for conduct problems. Those were the ones implemented by his provider. But given his circumstances, this might require a level of flexibility to address depression symptoms as well. So how do we do that? How can we kind of move back and forth between these 2 existing modes of intervention? And how do we prioritize which symptoms to address first? Do we address the conduct, or do we address the depressive symptoms? This is a familiar dilemma placed by many mental health professionals. And to address that, there is a treatment approach that is just beginning to show research evidence. So when implementing manualized treatment approaches for those like depression, clinicians often feel lost when they have multiple diagnoses that they have to address. To address and respond to this concern, Torpeda and Wise created what's known as a modularized treatment approach called Modular Approach for Therapy for Children with Anxiety, Depression, Trauma, or Conduct Problems. For simplicity's sake, we'll just call this the MATCH treatment approach. MATCH is a transdiagnostic treatment protocol designed to be used with parents and children ages 7 through 13. When developing the protocol, the authors pored over the existing literature of evidence-based practices and interventions for treating the most common emotional disorders encountered by pediatric mental health professionals. The most common being anxiety, depression, trauma, and conduct problems. We see 2 of these, conduct problems and depression, presenting with our case study with Billy. The authors identified that the core elements of many of these approaches were common. And so what the developers did was they looked over existing evidence-based treatment approaches for these 4 different disorders and distilled them down. The result of this distills to common and unique approaches. The result of this distillation process were 33 independent treatment modules. A module you can think of as largely the content of one treatment session. And so what this treatment approach allows you to do is to mix and match the needs of the given child at that context. So So if in the session with Billy, in one session, he and his parents were reporting a lot of behavioral problems, you might pull a module from MATCH to address that problem, those behavioral problems. If you felt the need to address depressive symptoms, those were more pronounced, something came up that week, you can pull out that module and use it. I like to describe it almost like a choose your own adventure approach, where you can look at and consider the individual needs and environment and characteristics and circumstances of the child to inform at that week which approach to take. So each of the 4 areas, anxiety, depression, trauma, and conduct, are assigned to a set of core modules with other supplemental procedures to be used as needed. Some of the modules are unique to a given area. For example, there are some very specific approaches for treating trauma that are limited for treating trauma, whereas other modules are shared across different areas. For example, there's a module on relaxation. Relaxation can be used with anxiety, depression, conduct, and trauma. So how do you use MATCH, this kind of menu of options to inform your treatment? The MATCH protocol provides flowcharts that guide the selection of procedures covered in each session. Here is an example of the flowchart for depression. Rectangles here refer to specific modules, which often include handouts and resources. Circles represent problem areas that might occur that interfere with therapy that you might need to address, and each of these problems have its own corresponding treatment module. So you can see at the beginning here, there are some psychoeducational modules where you get acquainted with a child, you help them learn about depression, and then if they're able to proceed, then you can continue to the right in this diagram to specific depression interventions. If there are behavioral problems that might interfere or become more pronounced, you can go to the bottom left corner to address more behaviorally oriented areas. So for example, in the case of Billy, you might decide to prioritize treating his depressive symptoms. Thus, you could use this flowchart to map out a new course and begin the next session utilizing a module to treat or teach Billy how to better identify and revise negative thoughts. As behavioral problems emerge during the course of therapy, you could intersperse module or treatment sessions that focus on behavior management strategies, such as helping his parents learn how to effectively use rewards and timeout. In this way, the MATCH program provides considerable amount of flexibility when treating children with comorbid presenting problems. It also includes a lot of resources and handouts for parents that can be very useful. The program is designed to be a bit of an all-in-one toolbox with these resources for parents and children that are available in the manual, but also available online. Oops. So let's talk a little bit about some of the benefits and limitations of this approach. Before we get that, let's talk about the research. That's really the most important thing. So initial research on the effectiveness of MATCH has been promising. There is emerging evidence suggests that it's as effective as existing treatment approaches, and it's viewed favorably by clinicians. Although this type of modular approach is still in its infancy, and it has generally been limited to use with school-age children. Um, there isn't an existing match approach for work with adolescents yet, but it can be readily adapted for use with adolescents, in my perspective. So let's talk a little bit about the strengths. It addresses many of the concerns of current treatment approaches, that they're simply too inflexible. You get halfway into intervention for treating behavioral problems with someone like Billy, and those treatment approaches oftentimes don't provide the flexibility that MATCH does to supplement your intervention in a systematic way. Another benefit is that it has preliminary empirical support. When in the distillation process that I started with, what the clinicians or developers did was they looked at existing evidence-based approaches, the cognitive approaches, that behavioral approach that we discussed today, and other related approaches, and they distilled back down to those core aspects. And so in that way, it's evidence-informed in the approach. And we have seen its own support through these initial research studies. As I said before, it's also a toolbox that has a lot of resources. It's flexible. It's also been translated in Spanish, which is very useful, and it's accessible online. In terms of limitation, the manual is somewhat expensive, although you can think of it as 4 treatment manuals in one. I see that as much more affordable. Also, there is some limited training needed, but anyone familiar with evidence-based treatment approaches will see a lot of, will see these modules as being very familiar. Another limitation is that it is only designed for these 4 disorders. Now, these are the most common disorders encountered by clinicians, but it's not exhaustive. But despite these limitations, is an intervention that I would highly recommend. And so with that, we've provided, I've discussed a lot of risk and protective factors associated with suicide. And I've also provided an overview of major interventions used for treating depression among youth. Cognitive behavioral therapy and IPT and medication being the most common. I've also highlighted this novel, relatively newer approach, the MATCH program, which is an effective use.
Thank you very much for providing this wonderful overview, and we look forward to future trainings.
Much like,
thank you.
Thank you. In the case study. I hope this presentation will help you be able to recognize effective treatment approaches, so that you might familiarize with these treatment approaches, so when you talk to youth and parents, you can have them know what to expect. I've also decided to provide you with a list of resources here. This first book is coming into press, in which I co-authored by Betty Garcia and Randall Nerregard, which is called Strengthening the DSM, Incorporating Resilience and Cultural Competence. This is a book that I'm very proud of, and what its focus is on this, taking the resiliency perspective and diversity perspective when working with your clients. The diversity and resilient formation is I think that can help anyone working with kids in trying to conceptualize not only their presenting problems, but also to help inform interventions. Another book I like to recommend to all my students is this book by Schroeder and Smith-Boydston called Assessment and Treatment of Childhood Problems. This is a very user-friendly guide that focuses on many of the clinical problems anyone working with children will face in clinical practice. My last plug is for the National Child Traumatic Stress Network. This is a great online resource. It can be used with parents, but also with practitioners. This site provides a lot of resources. Some of them, many of them are trauma specific, but there are additional resources that aren't specific to trauma. They provide, for example, a database of effective assessment tools and interventions. It's really invaluable. With that, I'd like to wrap up my presentation. I've presented here my contact information. Please feel free to contact me at any time. Send me an email if you have any questions. I'm happy to address any questions you might have with this material. And I hope you found this presentation to be informative and that it helps you identify risk factors and protective factors when working with youth who might be at risk for suicide.
Great. Thank you so much, JP. And thank you so much for giving those resources that can accompany today's presentation.